Hello, thank you for tuning in. We are excited to kick off the Women's Health Symposium, and we will be discussing sex differences in CF. I will be joined by my colleague, Dr. Christina Montemayor. Dr. Montemayor is funded by both the CF Foundation and the NIH related to this research, and I also have grants from the CF Foundation. Sex differences in pulmonary diseases has been noted across multiple subspecialties, including asthma, COPD, interstitial lung disease, as well as cystic fibrosis. In all of these diseases, differences in outcomes between males and females has been found, but not always in the same direction. One of the first studies that showed women with CF have decreased survival was published in 1997. This was a CF Foundation patient registry study, and it looked at survival over time. And here in this, on the x-axis, you have age, and on the y-axis, you have your survival probability. Males are noted in the circles, with females noted in the triangles. And you can see there's a clear separation, with a median age of survival of 25 years for females versus 28 for males. This was further replicated in a second CF Foundation patient registry using data from 1995 to 2007. And if you look here in the same survival curve with age on the x-axis and percent survival on the y-axis, males are denoted in the straight line and females in the dotted line. And you can see here the same was found, with the average age of survival was 36 versus almost 39 for females. And looking at the multivariate analysis, female was associated with a 2.2 relative hazard ratio for death, so worst survival. Female sex has also been associated with increased rate of pulmonary exacerbations post-puberty. This was also a CF Foundation patient registry that spanned approximately 3 decades, from 1978 to 2007, and it evaluated the rates of pulmonary exacerbations per year in males versus females. You can see that in the blue, this is males, and the red is females. And you can see that they looked at time from before puberty to after puberty. And you can see that about 4 to 5 years after puberty, these curves separate. And the adjusted rate ratio for females was about 1.48, with increased rate of exacerbations. There are several hypotheses that have been postulated to explain these sex differences in CF. Anatomical differences may represent part of the sex differences. Females have smaller lungs and smaller airways. Pathogen acquisition may also be a reason that there are sex differences. So Pseudomonas is one of a common bacteria that CF patients acquire that we know has been shown with increased mortality and increased rate of decline in lung function. Females have been found to acquire that earlier than males, on average about 9.5 years old versus 11 years old. Other pathogens are also acquired earlier in females, including MRSA. There may be differences in comorbidities in nutrition, CF-related diabetes. Sex hormones have also been studied. Because sex hormones play a role in mucus production, there may be differences in mucociliary clearance, leading to further destruction of the lung. We just saw puberty may play a role on that as well. There's also been thought of whether treatment patterns and exacerbations can be playing a role as well. So let's talk for a few minutes about pulmonary exacerbations. These occur frequently in the lives of our CF patients. We know that they're associated with worse outcomes, worse quality of life, lung function loss, and time in the hospital. There are a wide variety of treatment practices across the nation and even worldwide. So the Pulmonary Exacerbation Working Group was formed in 2009 and was directed by the CF Foundation. And they tried to put together guidelines at that time, but there was really no consensus on treatment because there are very little guidelines on how we treat exacerbations. So the goal of this working group is to standardize treatment of pulmonary exacerbations. The first study that the STOP group conducted was an observational trial, standardized treatment of pulmonary exacerbations. This was conducted in 2014 to 2015. It was an 11-center site, prospective, but purely observational. We followed 220 patients who were admitted to the hospital for an exacerbation. The antibiotic selection and duration was determined by the treating physicians, but we collected data, specifically lung function and symptom diaries, during a 28 days. And the treatment patterns and outcomes were captured. One of the key findings of this study is that only 65% of those 220 patients recovered to within 90% of their baseline lung function. So we know that 35% are possibly losing permanent lung function. So this led our group to wonder if there are sex and gender differences in treatment and outcomes in CF pulmonary exacerbations. I'm going to next let Dr. Cristina Montemayor share our research with you and discuss further.
Thank you, Natalie. I'm happy to take over now. And we were interested in whether there was a sex difference in pulmonary exacerbation occurrence. So we first looked at data from our center from 2016 to 2017. During that time frame, we had 158 adult males and 146 adult females. And what you can see was that there was a significant difference in females who were more likely to have a pulmonary exacerbation over that 12-month time period. In addition to these findings, D.B. Sanders and colleagues have demonstrated that female sex has been associated with failure to recover to baseline lung function after treatment with intravenous antibiotics. And this also supports the worst outcomes that females with CF have been experiencing. So what we did utilizing the STOP cohort was really try to look at treatment differences in pulmonary exacerbations. And there were 5 main outcomes that we looked at. We had 2 primary outcomes, one being the duration of hospitalization, 2 being the duration of IV antibiotic therapy, and then secondary outcomes included the CF respiratory symptom diary and chronic respiratory infection symptom score. And this is a validated patient-reported outcome tool in individuals with CF greater than or equal to 12 years of age. And for those of you who are not familiar, the scores range from 0 to 100, with the higher the score basically is the worst symptoms that someone has. And a change in score of 11 units is a minimal clinically important difference. We also looked at mean lung function measured by FEV1% predicted, as well as IV antibiotic selection. As Natalie mentioned earlier, there were 220 participants enrolled in this study, and we found that there were 80% adults, so greater than or equal to 18 years of age, and then 20% pediatrics. And for this study, it was those individuals 12 to less than 18 years of age. It was 56% females. And what our team did was we actually looked at the variables to see if there were any difference between males and females, and we found no significant difference in baseline patient characteristics or demographics. So we then did a regression analysis to evaluate the association of female sex with IV antibiotic duration and inpatient length of stay. And what you can see in both our unadjusted as well as our adjusted models, we found that female sex was associated with a higher risk of IV antibiotic treatment days. Notably, in our adjusted model, we identified factors a priori that were included, including age of enrollment, body mass index, cystic fibrosis related diabetes, delta F508 mutation category, pancreatic enzyme use, Pseudomonas infection, as well as baseline lung function. And what you can see here is in the overall cohort, there was a 13% higher risk of more treatment days with IV antibiotics for females. You can see, again, that met statistical significance in our adult population, so a 15% higher risk of days of treatment of IV antibiotics. And our pediatric cohort here neared significance, but there was a 26% higher risk of days of IV antibiotic use. We then looked at to see if there was a significant difference in score at the end of IV therapy. As Natalie described, end of IV therapy was going to be equating with visit 3 And just an important notice is that there was no kind of standardization of when this could occur for patients, so there was some variability. And what you can see here, specifically at the end of IV therapy, there was a difference between the symptom scores being reported between males and females. So females had a higher symptom score, indicating worse symptom severity compared to males. And this was particularly driven by the pediatric cohort. So males were reporting a mean symptom score of 9.9 compared to 21.3 in females. And I think that raises the question, did pediatric males have a better response to treatment compared to pediatric females? Again, these are patient-reported symptom scores, and studies have shown that females tend to be higher symptom reporters compared to males, so we definitely need to take that into consideration. But I think what we can infer from this is that the longer treatment may have been clinically necessary, and would like to propose that future studies collect symptom data daily to see if females take longer to reach the MCID, or if they reach it at the same time but get more treatment. So I think overall, a couple of notable findings, and I think can kind of propagate future studies. But we did find, looking at the overall analysis, some things I didn't present visually for you today, but we found no sex differences in antibiotic selection, in patient length of stay, or mean FEV1% predicted. We did say that female sex was associated with a 13% higher risk of IV antibiotic treatment days. On average, females were treated 1.7 days longer than males, and females reported worse symptoms at the end of IV therapy compared to males. From this analysis, though, I think we could say that the outcome differences we observed aren't due to failure to provide the same level of care for females and males. But what they do suggest is that as we move towards personalized medicine in cystic fibrosis, we need to grasp a better understanding of why the same treatment is not resulting in the same outcomes in males and females. And I think what Natalie and I have both discussed so far really emphasizes the need to have more research focused on women's health, what the CF Foundation has acknowledged and supports, and we are so fortunate to have a symposium dedicated specifically to this topic. In fact, the CF Foundation has created a women's health working group. It's currently led by Jennifer Taylor-Cousar, Raksha Jain, Maura Aiken, Natalie West, and Tracy Kazmersky. And these 5 women are helping kind of lead the efforts of this and working and collaborating with other researchers in the field to help answer some of these questions. So we're excited to share, hot off the press, Natalie West, myself, and our wonderful biostatistician, Kevin Soder, who is our CF biostatistician and who's supported by the CF StatNet Award, are actually looking at the epidemiology in sex differences in pulmonary exacerbations. And what you can see here in this graph, on the y-axis is the average number of pulmonary exacerbations per year, and on the x-axis is age. And what we did was include data from the registry from 2006 to 2016. And I think what's notable is that the sex differences that we see are actually occurring in childhood. So Natalie talked earlier about puberty, that these differences start much before puberty. So I think that raises an important question. And what you can see over time is that females do have more exacerbations per males. I think going over here to the right around age 60 is where they meet. So we're actually going to be looking at age-specific annual estimates and extending the age group to try to get a better understanding of the potential implications of the effects of menopause in CF. And I'm going to go ahead and let Natalie, who's one of the national principal investigators of the STOP2 cohort, explain this slide.
Thank you, Christina. So now I'm going to explain the STOP2 clinical trial that just finished earlier this year. So in this clinical trial, we have 3 visits. Visit 1 is when the patient or subject is diagnosed as having a pulmonary exacerbation. And that means with IV antibiotics with a decision that was made by the physician to treat with IV antibiotics for either increase in symptoms, worsening in lung function, or both. Visit 2 occurs 7 to 10 days later. And at that point, the subject is then randomized based on their original response to IV antibiotics. So you have an increase in 8% in FEV1 and a decrease in your symptoms, we would designate you as an early robust responder, ERR. And at that point, you'd be randomized to either 10 days of therapy or 14 days of therapy. And then the third visit, the follow-up visit, would occur 14 days later. Our hypothesis in this arm is that 10 days is not inferior to 14 days. If at visit 2, the FEV1 or the improvement in symptoms does not occur, then you were called a non-early robust responder, NERR. And the subject would be randomized to either 14 days or 21 days. And in this arm, the hypothesis is 21 days is superior to 14 days. Sonia Helchi, our biostatistician who is analyzing this study and actually was designed this particular study, will be discussing the results of the STOP2 study in her talk on Friday, October 23rd, in the Targeting Infection During Pulmonary Exacerbation Management Symposium. Myself, Sonia, and Christina will also be evaluating sex differences from this cohort as well.
Thank you, Natalie. Another area of ongoing research includes sex hormones. So myself, Raksha Jain are looking at the association of sex hormones and respiratory health in women with CF. What you can see here, this is from Schaefer and Jain. They were looking at DHEAS, which is a circulating androgen that correlates with disease severity in other chronic diseases, including asthma. And what they found here is that the DHEAS levels are disproportionately lower in women with CF. Another particular interest for me is trying to expand on this slightly and be able to actually look at additional hormones. So part of my work for the Harry Schwachman Award will be including how to evaluate how the effects of testosterone, DHEAS, estradiol, and progesterone impact respiratory outcomes. Since we are now in the era of CFTR modulator use, I know many of you are probably thinking, and it's important to look at sex differences in response to modulator treatment. What you can see here, this is by Secunda and colleagues, where they utilized the GOLD cohort, which included people with CF with at least one G551D mutation who were started on ivacaftor. And then they looked at a 2.25-year period after initiation of ivacaftor and found that females had a greater reduction in pulmonary exacerbations. On the y-axis, you see the annualized pulmonary exacerbation rate, and on the x-axis, you actually see pre-ivacaftor, post-ivacaftor. And while you notice that the pulmonary exacerbation rate decreases for both females, which is here in green, and males, which is here in blue, there's a significant decrease in pulmonary exacerbations in females compared to males. And lastly, courtesy of Raksha Jain, this is one specific area of her interest, and she wanted to kind of expand on the ivacaftor use and looking at more long-term sex differences, so expanding beyond that 2.25-year follow-up. So she'll be looking into that. And then also determining the differential responses to lexicaftor, tezacaftor, ivacaftor in males versus females, as well as in those females on and off oral contraceptive therapies. I know Natalie and I would like to thank you today and thank you for allowing us to be part of the symposium, and we'd both be happy to answer any questions. I know in the live chat, we'll be seeing you Wednesday, October 21st.
Good afternoon. My name is Raksha Jain. I'm an associate professor of medicine at the University of Texas Southwestern in Dallas. I'm going to be giving this talk along with Dr. Jennifer Taylor-Cousar, a professor of medicine and pediatrics at National Jewish Health in Denver, Colorado. Today, we're going to be talking about fertility and pregnancy in cystic fibrosis in the era of highly effective modulator therapy. These are my disclosures, none of which are relevant to today's topic. So just to give you a brief outline of what we're going to be discussing today, we're going to start by an overview of what's known on the epidemiology and hypotheses behind the etiologies of infertility in women with cystic fibrosis. We're then going to move into the implications of modulator therapy on fertility, followed by a review of some of the data on what women with CF desire to know regarding sexual reproductive health. Then Dr. Taylor-Cousar is going to move into a review of some of the cohort studies that have been done related to pregnancy and cystic fibrosis, along with the impact of highly effective modulator therapy on pregnancy, followed by some of the ongoing and upcoming studies on these topics. So just to begin with, when it comes to fertility in women with CF, it's important to understand that the anatomy, the reproductive anatomy of women with CF is similar to that of women without CF, unlike what we know about men with CF who have absence of the vas deferens. When it comes to the frequency of infertility in women with CF, it's actually quite low. We don't know the exact percentages because this has not been systematically studied. There has been some reports, including one by Steinberg et al., that reports a 35% subfertility rate in women with CF. And importantly, other studies show that 25 to 50% of pregnancies in women with CF are unplanned. So when it comes to the etiologies of this infertility, there's been a number of different hypotheses, and we still have much to learn. But some of these hypotheses include that women with CF may be malnourished and therefore have altered ovulation. There may be a component of delayed puberty or delayed menarche impacting fertility. Others have suggested a decreased or diminished ovarian reserve. And I think the leading two hypotheses are that women with CF have potentially thickened cervical mucus or thickened cervical secretions, along with alterations in their pH in the reproductive tract that's impacting their fertility. And I'll move into a little bit more about these. So first, to understand the impact of CF on women's reproductive tract, you have to understand the distribution of CFTR in the reproductive organs. So first of all, the cervix is an area that's thought to have very high expression of CFTR. This high expression of CFTR in the cervical epithelium results in dehydration of the cervical mucus, similar to the dehydration we'd see in the airway secretions in someone with CF. In addition, there's lack of cervical thinning, and these two things combined make it very challenging for sperm to penetrate through the cervix. There's thought to be fairly moderate CFTR expression in the uterus, and here CFTR plays a key role in regulating uterine fluid volume. In the fallopian tubes, there's also thought to be potentially moderate CFTR expression, and this plays a role in egg transport through the fallopian tubes. And finally, in the ovaries, there's little to no CFTR expression. Another important impact that CFTR can have on fertility is the effect on sperm itself. So as is very important, the typical uterus in women has a high bicarbonate presence, and therefore this alkaline pH is actually quite critical for sperm motility and sperm capacitation. Capacitation is really the maturation process sperm have to go through to shed their outer polysaccharide layer in order to be able to appropriately fertilize an egg. CFTR impacts this bicarbonate presence and lowers this pH, which makes it much more challenging for the sperm to mature. In addition, as I mentioned before, CFTR regulates the uterine fluid And these two things combined can impact sperm transport and sperm maturation, again, making it slightly challenging for women with CF to become pregnant. So what do we know about the impact of CFTR modulators on fertility? Well, when you look at the prescribing information of the 4 main approved compounds of CFTR modulators in the United States, there has been some information provided on the impact of these compounds in animal models. And at very high doses, there was some impaired fertility reported in animals when it comes to ivacaftor and elexacaftor, with no effect from lumencaftor and tezacaftor. But at normal human doses, there's been no impact on fertility reported. When you look at the impact of highly effective modulator therapy on fertility, there may be an increase in fertility that's beginning to be reported. Some of this is hypothesized to be from general improved health of women with CF and therefore improved nutritional status. The other has been thought to be from decreased cervical mucus, as we talked about, or decreased tenacity of these secretions in a more normalized pH environment, making it much more feasible for them to become pregnant. There have been some studies looking at pregnancy rates, particularly in regards to women eligible for ivacaftor. So in the ivacaftor trials themselves, it was reported that 2% of women became pregnant, and these were in women who were supposed to be on contraception during these trials. In addition, there's been several case reports of unintended pregnancies in women with CF. And finally, when you look at the graph to the right of a study reported by Sonia Helshi and colleagues in the Journal of Cystic Fibrosis in 2017, the green line depicts women from the CF Foundation Patient Registry who have G551D mutations and were followed over time. And you look at the rate of pregnancy in these women, and there was a slight uptick towards the end of these ivacaftor clinical trials. And in 2012, when ivacaftor was approved, you see this increase in pregnancy rates in this group of women. Additional literature following women with CF on modulator therapies, there was a survey done in CF mothers, and actually the study showed that 7 women who reported previously being told they were infertile or infertile in some way actually became pregnant after starting ivacaftor. So again, we have much to learn in regards to this topic, but some of this data is suggesting a potential improvement in fertility from highly effective modulator therapy. Dr. Andrea Rowe at the University of Pennsylvania has recently been funded by the CF Foundation to study cervical mucus in women with CF. She is planning on a cross-sectional assessment of mid-cycle cervical mucus, where she's going to compare the cervical mucus quality in women without CF to women with CF off modulators. In addition, compare the cervical mucus quality in women with CF on modulators to women not on modulators. This will be a study that enrolls approximately 30 plus women, and we look forward to hearing about these results. So finally, it's important to understand that there have been surveys done understanding what women want to know in regards to sexual reproductive health in CF. There was a fairly large retrospective multinational study done in Europe and the UK of over 600 women. In this study, it showed that approximately 40% of them attempted to get pregnant. In addition, Tracy Kazmersky and colleagues surveyed almost 200 women in the United States with CF and found that many of them seek to know more about sexual reproductive health, including pregnancy. Approximately 80% of young women reported that they wanted to have children in the future. And in another study in Australia of women with CF, with a slightly higher mean age in the 30s, they reported that over 50% of them had actually tried to get pregnant, and all of them wanted children. They also reported difficulty accessing information on sexual reproductive health. Amongst the topics that they reported they wanted to know more information about, it included topics of fertility, the safety of pregnancy, the impact of pregnancy and childbirth on their future health, and information on the safety of medications during their pregnancy. With that, I'll turn it over to Dr. Jennifer Taylor-Cousar, who's going to talk more about what we know about pregnancy and the impact of highly effective modulator therapy in women with CF.
Thanks, Dr. Jane, and thanks to Drs. Kazmersky and Rowe, as well as the organizers of the conference, for the opportunity to present today. These are my disclosures. So Dr. Jane mentioned that there has been an increasing report of a desire of women with CF to become mothers, and we are seeing that borne out in the US CF patient registry. On the y-axis of this graph, you see the number of pregnancies, and on the x-axis, the year. So over time, there's been a generally steady increase in the number of pregnancies per year, and the top line shows the percentage of women in that year who are becoming pregnant. So you can see that overall, more women with CF are having babies. So what do we know about pregnancy and outcomes in cystic fibrosis? There have been a great deal of individual site retrospective studies. However, there have also been some database studies. So for example, Dr. Goss used the CF patient registry in a cohort from 1985 to 1997. And they reported that women with CF who became pregnant were healthier at baseline and had better 10-year survival compared to those who didn't become pregnant, as shown as the Kaplan-Meier curve on the right. Subsequently, Dr. Schechter and colleagues looked at data from the epidemiologic study of CF. That cohort was from 1994 to 2005. In their cohort, women with CF who became pregnant had more illness-related visits, more pulmonary exacerbations, including the need for intravenous antibiotics, and lower quality of life scores. Importantly, women with CF who became pregnant did not have accelerated disease progression or increase in mortality. In contrast, a recent Italian registry-based case control study showed that women with CF experienced health decline from 6 to 12 months pre-pregnancy to 1 year post-pregnancy. There have also been some large database studies that looked at both maternal and infant outcomes in women with CF. In the first example, the researchers used a national inpatient database to review outcomes of pregnancies in women with CF. They found that complications were more common in women with CF compared to those in the general population, particularly diabetes, infection, and preterm labor. Another group used 4 California health databases to look at perinatal and maternal outcomes. They found that in 66 pregnancies of women with CF, infants of women with CF had more congenital anomalies, more than twice that in the general population, increased rates of jaundice, C-section, and premature delivery. They also reported that women with CF had 3 episodes of gestational hypertension and 3 episodes of preeclampsia, 1 reported as severe. More recently, in a publication from July of 2020, a group looked at the UK Obstetric Surveillance System review and studied women with CF who had infants. They found that there was a direct correlation between lung function and gestational age. So the lower someone's lung function, the more likely they would be to have a premature baby with low birth weight. Another consideration besides outcomes is medication use during pregnancy and lactation. Previously, the FDA categorized drugs as A through D or X. So A meant that there was a great deal of data and we think it's safe in pregnant women, versus X, which meant never give it to a pregnant woman because of the extreme outcomes on the infant or the fetus. That categorization system was felt to be oversimplistic. So now we use a pregnancy and lactation labeling rule. Sponsors have several requirements, including they must say, are there adequate and well-controlled studies in pregnant women to say if there's a drug-associated risk of major birth defects or miscarriage? Also, the sponsor must say, in animal studies, how much drug was given compared to the maximum recommended human dose and what happened to the fetus as a result. The modulators have been studied individually in animal reproductive models. So if you look at the category of pregnancy and teratogenicity and look at the individual modulators, you can see that for ivacaftor and elexacaftor, given at toxic doses to maternal rats, there was an association with decreased fetal body weight. And in the case of tezacaftor given to rabbits at toxic doses to the maternal rabbit, there were decreased fetal body weights and early developmental delay in pinna development, in pinna detachment, and eye opening. Again, these were at toxic doses, so we did not see these effects at normal human doses. From the animal models, we do know that each of the individual modulators is present in breast milk. Importantly, when ivacaftor was given to neonatal rats, so those that were 7 to 35 days old, they did develop cataracts. So there is a rule about examining the eyes of infants or children who are given ivacaftor either alone or in combination to look for cataracts. So I talked about the risk to the fetus in the infant. In pregnancy, you have to compare the risks to the fetus to the risk to the mom of stopping the drug. So what do we know about stopping modulators? Doctors Donaldson and Trimble reported in 2018 something called ivacaftor withdrawal syndrome. There are 3 cases in their case series. You can see those on the right. FV1 is reported on the y-axis and time on the x-axis. Those who stopped their modulators suddenly had significant declines in their lung function and health. And you can see that unfortunately in one case, cessation of ivacaftor unfortunately led to death. In 2018, Carpino and colleagues also reported at the North American CF meeting on the cases of 10 adults who were in the triple combination phase 2 studies. They reported that post-participation in triple combination therapy studies, their trial participants experienced in 7 out of 10 cases lung function decline, and 5 pulmonary exacerbations occurred within 4 months of stopping triple combination therapy. So there are some people who experience rapid decline after stopping modulators. So unfortunately, we have these potential risks, although they seem very low from animal models, for using modulators during pregnancy, and this risk that has been described in people of the possibility of health decline from stopping modulators, but there's really a paucity of data outside of case reports for modulator use during pregnancy. Therefore, Doctors Nash, Middleton, and I collected data from across the world from clinicians whose pregnant women stayed on modulators for part or all of their pregnancy. We found that in 61 women with CF, the use of CFTR modulators during part or all of their pregnancy only resulted in 2 maternal complications that the clinician deemed was related to the CFTR modulator therapy: 1 episode of pulmonary exacerbation and 1 episode of acute myelocytic leukemia. We felt that was probably unrelated to the modulator therapy, but that decision was left to the clinician. We found the miscarriage rate of women with CF on modulator therapy was 4.7%, which is lower than the miscarriage rate that is reported in the general population of 10 to 15%. Importantly, cessation of modulator therapy resulted in clinical decline in 9 women, resulting in the reinitiation of modulator therapy during pregnancy. Finally, no modulator-related complications were reported in infants exposed either in utero and or during lactation. Of course, this report only included women on IVA, Lumivia, or Tez-IVA. At that point, we had no data on women who stayed on Alex Tez-IVA during pregnancy. Therefore, Dr. Jane and I have continued to collect data on women who stayed on Alex Tez-IVA during their pregnancy. Thus far, we have received 11 reports of women who stayed on Alex Tez-IVA during part or all of their pregnancy. In 7 of 9 live births, Alex Tez-IVA was continued throughout the entire pregnancy. 2 women experienced early first trimester miscarriages. In this chart, I'm showing you the maternal and infant complications along the y-axis, and then on the x-axis is the relation to Alex Tez-IVA that was determined by the treating clinician. You can see that most complications were unrelated to Alex Tez-IVA, including hemoptysis, malnutrition, preeclampsia, gestational hypertension, preterm labor, an episode of prolonged epidural headache, and 3 episodes of prematurity. There was 1 episode of preeclampsia that was deemed of unknown relatedness to Alex Tez-IVA. The mother in this case had a post-Alex-Tezaiva FV1 of 29% predicted and was on 5-drug therapy for M. abscessus at the time of conception. Unfortunately, her infant was born at 25 weeks and died of complications of prematurity and infection. In the case of the other 2 complications that were reported as unknown in relation to Alex-Tezaiva, there was one infant who had a choroid plexus cyst and ureterocele, as well as transient transaminitis. And there was another infant who had a mild aortic coarctation. In this child, the mother had very poorly controlled CFRD, which is a known risk factor for congenital heart malformations. Because of the paucity of data in the modern era, as well as on modulator therapy, we are currently conducting a retrospective multi-center study to look at the impact of pregnancy on maternal outcomes. We are hoping to gather data on 300 women at approximately 10 centers. We'll collect data both from the electronic medical record as well as from the CF patient registry. However, this will still be a retrospective study. What we really need in CF, which has never been done before, is a prospective multi-center study looking at pregnancy outcomes. So in the spring of 2021, we'll start the Mayflower study. Our primary objective is to determine the effect of pregnancy in the setting of CF on maternal health, delivery outcomes, fetal outcomes, with a particular focus on the impact of modulators on maternal and fetal health. We'll have 2 sub-studies, one a pharmacokinetic studies of the modulators in the infants and the mothers, and one on maternal continuous glucose monitoring to really look at how diabetes control impacts pregnancy in CF. So in summary, fertility is likely increased by CFTR modulation. There's an ongoing study of cervical mucus quality by Dr. Rowe that was described by Dr. Jane. We know the desire of women with CF to become pregnant and have more information about pregnancy and pregnancy rates are all increasing. There is insufficient data in the modern era, so we're currently conducting a retrospective multi-center study of maternal and fetal outcomes. Finally, approximately 90% of the adult CF population in the US is now eligible for highly effective modulator therapy. There is minimal data available if continuing or stopping HEMT in pregnancy is safe. Therefore, we'll start the Mayflower study in the spring of 2021 to look at maternal and fetal outcomes in the era of CFTR modulators. I'd like to thank the CF Therapeutics Development Network for their support of the Women's Health Research Group and the CF Foundation for their support of all of these studies. Also, thank you to the contributing centers who gave us data on Trikafta in pregnancy. Thank you.
Hello, everyone. Thank you for being here today to listen to my talk entitled Urinary Incontinence in Women with Cystic Fibrosis. My name is Megan Bradley, and I'm a urogynecologist at the University of Pittsburgh Medical Center, McGee Women's Hospital in Pittsburgh, Pennsylvania, where I see a variety of different patient populations experiencing pelvic floor disorders ranging from prolapse to urinary incontinence and other more rare issues. I have no disclosures. The objectives for today's talk are to discuss the background and available data on urinary incontinence in women with cystic fibrosis. We'll review the physiology of the bladder and the symptoms of urinary incontinence, including urgency urinary incontinence, stress urinary incontinence, and mixed incontinence, which is a combination of both. We'll discuss how we tend to approach the diagnosis of urinary incontinence and then focus on management options, including the risks and benefits of each of these options for patients experiencing urgency, stress, or mixed incontinence. So we know that universally urinary incontinence is common and undertreated, and this is true for really all patient populations. In 2008, there was a cross-sectional analysis of 1,900 non-pregnant women from 2005 to 2006 as a part of the National Health and Nutrition Examination Survey. And they found that 15% of women experience urinary incontinence, with this proportion increasing incrementally with age. And really only 25 to 60% of symptomatic women seek care. And this reluctance is likely due to embarrassment, lack of knowledge about treatment options, and fear of these treatment options, And also a lot of women just report that they felt like they were supposed to deal with urinary incontinence as a part of either aging or just being a woman or after pregnancy. And hopefully by the end of this talk, you'll know that that's just not true. So advances in therapy and management have led to dramatic increases in life expectancy of patients with CF. A systematic review in 2018 sought to consolidate all of the current literature surrounding urinary incontinence in patients with CF, found a total of 12 research papers that report the prevalence of UI all the way from 5% to 76%, with it being more prevalent in adult female patients. But there's really a lack of consistent definition of urinary incontinence and the way to delineate severity and impact of quality of life in this patient population. Focusing on adult women with CF and UI, the prevalence ranges from 30 to 76%. In general, it seems to be small amounts and variable frequency, anywhere from occasional to up to 4 times a week or even daily, and the relationship to disease severity is unclear. Of the 7 articles that comment on the impact of UI on airway clearance, exercise, and/or spirometry, anywhere from 16 to 42% of patients report that UI limits effective airway clearance, which is obviously very important for this patient population. And there's really a variable quality of life impact. Some papers report only 20% of patients report that their UI is a bit of a problem. Other studies report 29 to 42% find that UI really affects their social life, school, and work a lot or most of the time. Much like the general population, it seems that affected patients with CF likely underreport symptoms to providers, with less than a third of patients with CF and UI having already discussed the issue with their healthcare provider. And again, what we don't know is this due to a low level of bother or embarrassment, lack of knowledge about options. Recent unpublished data from an abstract at this current conference looked at a large multi-center survey of over 400 women with CF greater than or equal to 25 years old, and found that 50% of women have some degree of urinary incontinence, with upwards of over even 13% experiencing daily symptoms. Activities such as coughing and airway clearance are reported as primary triggers, with almost 40% of women reporting some degree of impact on their ability to effectively complete their chest physiotherapy. And 27% have never discussed their symptoms with anyone, and less than 30% of women with CF have spoken to their CF care team about it. So what's the cause for urinary incontinence in women with CF? So to back up a little bit and discuss the 2 functions of the bladder, storage and elimination, we know that the parasympathetic system is important in terms of bladder's ability to empty, with acetylcholine activating the muscarinic receptors on the bladder, and that the sympathetic system, originating from the pelvic plexus and hypogastric nerve, utilize norepinephrine to activate beta-adrenergic inhibition of the bladder and stimulate the urethra to maintain continence. Really, any level of malfunction of the bladder, urethra, sphincter, central or peripheral nervous system can lead to urinary incontinence or retention. An overactive bladder, which I'll define in a few slides, is believed to be caused by alterations in the sensation of afferent nerves, malfunction in inhibitory systems, and the true mechanism is really unknown. And we find a lot of patients with chronic illness have overactive bladder, and that is something that we don't totally understand. In terms of stress incontinence, the historic kind of agreed upon pathophysiology, although it really is up for debate in a lot of circles, is this pressure transmission concept, where for continent women, if you have a rise in intra-abdominal pressure, like a cough or a Valsalva, this is transmitted equally to the bladder and urethra and you maintain continence. Whereas incontinent women, this bladder base descends into the vagina, the urethra rotates upwards during increases in intra-abdominal pressure, leading to stress incontinence. So for symptoms of urinary incontinence, or what patients are actually complaining about in terms of what they're experiencing, patients with overactive bladder or a gotta-go bladder are going to describe urgency, defined as a sudden compelling desire to pass urine, frequency, voiding more frequently than previously accepted, urgency, incontinence, involuntary loss of urine associated with this urgency, and nocturia, interruption of sleep 1 or more times to void. And these patients are the ones that are going to describe urinary urgency or incontinence. And they put their key in the door to get home. If there's running water or thoughts of a bathroom, if they're standing from a seated position trying to get to the bathroom, this can be overactive bladder. It can often be confused as an activity and associated with stress incontinence. And then there are patients that just have activity-induced overactive bladder, whether that's patients that run or walk, or even have a lot of coughing. This can induce overactive bladder and not necessarily be from stress incontinence. In terms of the signs that we might see on patients' actual physical exams of overactive bladder, we can actually observe transurethral leakage of urine when the patient is describing a sensation of urgency. And then overactive bladder syndrome, we define as urinary urgency, again, usually accompanied by frequency and nocturia, with or without urgency incontinence in the absence of something like a urinary tract infection or other pathology. And we will describe patients as having dry overactive bladder, meaning they really only experience urinary urgency or frequency, all the way to wet overactive bladder where they're actually having incontinence episodes. In terms of stress incontinence, this is again, the complaint of involuntary loss of urine on effort or physical exertion, like sporting activities, sneezing, coughing, chest physiotherapy, and mixed incontinence, which often is the most common type of incontinence, is really when patients have some degree of both stress and urge issues. So specifically for patients with urinary incontinence and cystic fibrosis, most papers suggest that the principal pathophysiology of UI and CF is stress incontinence, but a lot of this data is really based on just questionnaire data. The majority of studies that even delve into the etiology of incontinence in this patient population utilize the King's Health Questionnaire with a relevant excerpt listed here, which really just asks patients how much these things are bothering them, like frequency, nocturia, and stress incontinence being reported as urinary leakage with physical activity. But again, this isn't going to necessarily 100% guarantee that the pathophysiology is due to the stress incontinence, because patients can have activity-induced overactive bladder. This is one of the larger studies looking at the types of UI in women with CF. 146 women were surveyed with a mean age of 28 years. 74% of this patient population was experiencing some degree of urinary incontinence that they report as stress predominant symptoms based on the King's Health Questionnaire, but again, no objective exams were performed. 60% of patients described mild symptoms, but patients also kind of talked to the patients about what the different types of incontinence were before they answered the questionnaires, so there could be to some degree of bias. And again, there's really no published papers showing objective exams in women with CF, and I think going forward, this is probably an important area of research to consider. In terms of the way that we diagnose urinary incontinence and how we think about patients that we are seeing in clinic, it's really pretty straightforward. We are just going to get a detailed history, a very focused physical exam, consider either a urine dip or urinalysis to rule out any urinary tract infection if there's some symptomatology of that. We may check a post-void residual simply with an ultrasound on the suprapubic area to make sure that we're not missing any kind of incomplete bladder emptying or urinary retention. We'll probably check the patient's pelvic floor muscles and also have them complete something simple like a bladder diary, which is a really excellent way to get a snapshot of their kind of objective urinary habits outside of your clinic. You can spend a lot of time asking patients, how often do you go? Are you going a little? Are you going a lot? But really just getting an objective amount of data for maybe 1 to 3 days, looking at how much patients are drinking, when they're going, how much they're going, what are their triggers for leakage episodes, can be incredibly helpful. And what's really not necessary and important for patients to understand prior to coming to see us is that we're not really going to do anything invasive, and certainly not at the beginning visits. There are things that we do like urodynamics, cystoscopy, and cystometrics, which I'll discuss, but it's very uncommon that we need to do these things in somewhat uncomplicated cases. So for stress urinary incontinence specifically, we really should demonstrate this before any surgery is performed, but this is not necessarily important if you're not going to do something more invasive. You can diagnose stress incontinence either as simply as someone having bad stress incontinence, not even having a full bladder, doing a pelvic exam and having them cough and no leakage, which we designate an empty bladder cough stress test. but sometimes we will do simple cystometrics, we'll discuss in a moment, and multi-channel urodynamics using pressure catheters are really not necessary if either of the other less invasive options are positive. Simple cystometrics is as simple as having patients have a pelvic exam, start with an empty bladder, see if they leak when they cough, even with an empty bladder. And if they don't, we just pass a thin catheter into the urethra and gradually fill their bladder with water. It's very uncomplicated and pretty straightforward. We assess sensations, how full their bladder can get, if there's any urge incontinence during the fill, and then when their bladder is comfortably full, we check again to see if they leak with cough or Valsalva to diagnose stress incontinence. We also will tend to just briefly assess urethral mobility, which, as discussed before, is kind of the displacement angle of the urethra. When someone Valsalvas or coughs, does that bladder neck descend and the urethra move up? It's diagnosed technically by at least 30 degrees change from the horizontal. We used to do tests with a Q-tip where we put a Q-tip in the urethra and looked, but we don't do that anymore. So again, you can assure patients that they're not going to likely have things kind of put in the urethra unless we absolutely have to do something like cystometrics. So now to focus on treatment of urinary incontinence. Because treatment options do vary sometimes by incontinence type, it is important to try and determine the etiology and severity of the patient's symptoms to help you gear what you're going to offer for them. So the initial options for both stress and urge incontinence are similar. There's bladder training, behavioral therapy, trying to have patients time their voids, and Kegel urge suppression, which we'll talk about in a moment. And then pelvic floor muscle therapy can be an option for both types of incontinence. Beyond these conservative options, though, is when we have to start trying to think about what might be the real cause of the patient's symptoms to decide if we're going to move down maybe more a pharmacotherapy path for urge incontinence, or maybe support devices, or even surgical options for stress incontinence. So the good thing is that pelvic floor muscle exercises are pretty simple, go with patients everywhere they go if they can learn to do them effectively, and can help both stress and urge incontinence. And these can be done with or without pelvic floor physical therapy. Voices for PFD is a really excellent website that has different handouts for patients that can allow them to sometimes do these pelvic floor exercises and bladder training on their own at home if we feel like they have a good assessment of their pelvic floor already. And they're just written in a nice way for patients to understand these different words that we're using and try and do some of these things at home. But if we feel that they might benefit from pelvic floor therapy or pelvic floor muscle therapy for their symptoms, then we really try to normalize this. I often explain to patients that if you had a hamstring injury, you would go to physical therapy, or a knee injury, and there's no reason why we can't have patients do physical therapy for their pelvic floor muscles, even if they're nervous about it. And I really try and reassure them that it can be very effective, especially for urge incontinence. You know, we do see that it can be helpful, although we have a little bit lower evidence for this over stress incontinence. We often combine it with other behavioral therapy. There are things like biofeedback that don't necessarily seem to help a lot. We'll have patients often ask us about different devices they see online about biofeedback, but I still really try and urge them to see a pelvic floor physical therapist to learn what is going to be the best option for themselves. For stress incontinence, there's definitely more data based on larger studies with either active or placebo controls that does show that pelvic floor physical therapy can really increase continence rate and improve incontinence episodes more than usual care for patients with primarily stress incontinence. And it does seem that even with bladder training, this can help even more so. So specifically for patients with cystic fibrosis, there has been one pretty small study done that actually was initially looking at patients with different chronic pulmonary illnesses, including COPD, but specifically looking at the CF side of this study. They had 27 of the 38 women with CF had a degree of incontinence, which is kind of similar to the previous studies we've discussed. This is 71%. And this is related to only 40% of age-matched controls, which is pretty striking. And only 8% of these women were Paris. And you can see here that most of the patients had kind of some, either a little, somewhat, or great deal, approximately 50% of bother, with about 50% of the patients with incontinence not really bothered at all by their symptoms. But 4 patients in this study went on to a trial of physical therapy, obviously a very small cohort. They didn't really find a difference in King's Health Questionnaire quality of life metrics after 3 months, but they did find a significant reduction in objective UI episodes per day after 3 months of physical therapy. Again, this is a very small study, and there's a lot of research that needs to be done about if patients like this option, if they feel like their level of bother is enough to warrant some kind of treatment like this in this patient population, but at least it was a start. We also have a lot of options for patients in terms of their stress incontinence that are non-invasive options like pessaries, which we can fit in the office, which patients can wear sometimes all the time, or sometimes just when they're doing things like their chest physiotherapy or going for a run, that can really help. And there's also over-the-counter devices like this Impressa made by Poise, which is a tampon-like device that presses up on the urethra to help prevent stress incontinence, and again, is a really non-invasive option for patients. There are also newer absorbable reusable underwear that in studies in patients with stress incontinence, when compared to the previous Impressa device, have shown to have improved quality of life metrics and good product performance in these patient populations, but we have an unknown utility in women with CF and UI. Briefly, in terms of urge incontinence, this is going to be treated primarily with pharmacotherapy when you think beyond the initial behavioral options or pelvic floor physical therapy. And there's really 2 types of medications, including anticholinergics and beta agonist therapy, which overall both probably improve symptoms about 60% if tolerated, but can have side effects. Specifically with the anticholinergics can be dry eyes and dry mouth and constipation. There's many different anticholinergic options, and there's really no compelling evidence for one agent over the other. And in terms of the beta agonist, this is a more a newer medication called Myrbetriq or Mirabegron that is often used if patients don't tolerate anticholinergic side effects. There have been a variety of different pharmacology options tried for stress incontinence, but the take-home point is that none of them have FDA approval for this, and they really don't seem to work. And then finally, in terms of surgery for stress incontinence, really the 3 options are mid-urethral slings, urethral bulking, or Birch copal suspension, which all seem to work about 85% of the time, but slings are really the gold standard for stress incontinence. Indications for retropubic, primarily mid-urethral slings, include symptomatic stress incontinence affecting the patient's quality of life, and we usually would prefer patients to have failed conservative treatment options. And then whether or not they need to have completed childbearing is a point of a little bit of debate, but it's a very minimally invasive procedure, and there's really no consensus about when patients have to be done with childbearing in order to have a sling. It's really not probably an absolute contraindication if someone is exceptionally bothered, and there's actually a pretty recent case series that shows the safety and efficacy of slings even prior to a final vaginal delivery. And there has been one study looking at slings in stress incontinence for women with cystic fibrosis. Again, a very small case series, 4 women, but 2 were nulliparous. They had all tried pelvic floor therapy prior to their sling. And this is a little bit of an old study, and people have come a little bit of a way in terms of how minimally invasive we approach slings at this point. But this particular study had all patients be admitted prior to surgery for IV antibiotics. Given the minimally invasive nature of the procedure, this is likely unnecessary, but would require conversations between pulmonology team, CF care team, urogynecology to perioperatively optimize the patient. But just because someone hasn't had babies yet or completed childbearing, it doesn't necessarily mean that they can't have surgical options if they're very bothered by their incontinence. So in conclusion, urinary incontinence in women with CF is very common, likely, seems to have a variable degree of bother, and it's probably important to figure out a little bit more about what type of UI is really happening in these patients, what these patients really want in terms of treatment options, and what their preferred referral patterns are to really learn how to best care for patients with urinary incontinence and cystic fibrosis. These are my references, and I thank you very much for listening to my talk.
Hello, my name is Molly Pam, and I'm an adult with cystic fibrosis. I live in San Francisco, California. I'm a patient partner with the Cystic Fibrosis Reproductive and Sexual Health Collaborative and the Family Matters column in the publication CF Roundtable. Today I will be discussing addressing sexual and reproductive health care as a woman with cystic fibrosis. I have nothing to disclose today, and I would like to give a note on language. So as I go through the presentation, I will be using the word woman for brevity. This is taken to mean as anyone who accesses gynecological care or who is born with female biological genitalia. I will also be using sexual and reproductive health as SRH, again for brevity. Today I will cover how women with CF currently access sexual and reproductive health care, patient and provider preferences for discussing sexual and reproductive health care, barriers to these discussions, life course timelines for when to discuss different topics, and I will present some new resources for facilitating these discussions. So women with CF receive sexual health care at lower rates than the general population. This is especially important for things like pap smears or HPV vaccines, which can prevent and screen for cancer. About half of women with CF have ever used contraception in their life, and of those half, the long-acting reversible contraception use is much higher than the population. And this is due most likely to the number of women who are on clinical trials. IUDs and implants are considered long-acting reversible contraception, and they're generally abbreviated as LARC. Many women with CF experience yeast infections, most likely due to antibiotic use. They experience sexual dysfunction and discomfort is really coughing, pain, or hemoptysis during or just after sex. And most women with CF want children. And we'll talk a little later about how that can happen. Most people with CF have reported they've never discussed any sexual and reproductive health care issues with their CF doctor, but a majority want to have these conversations. Most of the young adults do receive care from a gynecologist, but a few do currently use their CF physicians. This is most likely and often because people with CF really view their CF doctor as a primary care physician. And then the main source of information people get is from their parents, and this means that you need education about these topics from the parents as well. So when I talk to friends and other colleagues who are seeking care, the most important thing they want is they want that provider to have experience with CF. There are many CF-specific considerations for sexual and reproductive health care, including yeast infections, which with the newly approved modulators, antifungals and modulator use modulators have to be reduced, and that is something that a CF doctor can do that you would not want a gynecologist to do, for example. So now let's talk about what sexual and reproductive health care could look like in the CF clinic. Kazmersky et al. Did a study where they elicited opinions from providers and patients about what they want in sexual and reproductive health care. And as we go through the following slides, I will be reading off this, telling you the 4 major points. So sexual and reproductive health care is important to discuss in CF clinic. We already heard that patients want it discussed in CF clinic, but 75% of providers also think SRH care should be included in the CF care model. You can see some of the important topics that providers want on the side. 2, patient-provider comfort is often a barrier to care. The comfort comes from lack of time, lack of knowledge, lack of support, lack of education materials, and especially during transition, peds doctors are uncomfortable having conversations with patients they've known since infancy, and adult doctors are uncomfortable having these conversations with a patient they just met. So there's a little bit of a disconnect in that transition period. To overcome those barriers, there are many ways that providers can address this. A lot of providers say, I don't want to ask them because I don't know what to say. You can do some research. When I was looking into taking contraceptive pills for the first time, I asked my doctor. He said, I don't know, but let me do some research and get back to you. He sent me some articles and we had a really productive conversation. You can also consult another doctor. If you don't know someone who's an expert in the field, you can ask the CF Foundation. Again, from personal experience, when I had NTM or ABPA, my doctor asked me, do you mind if I discuss your case with another doctor who's much more of an expert in the treatment of this? And I said enthusiastically, absolutely, I want to get the best care possible. And then you can also refer your patient to another doctor. If they have a complex gynecological issue, refer them to a gynecologist. You don't need to do all of it in clinic. So the third point that Kaczmarski and all found from patients and providers was that they all wanted educational resources coupled with standardized questions to facilitate care in clinic. So they came up with an amazing graphic that you should go look at. I put some of the more important details here, but they created a framework for what areas of sexual and reproductive health care CF centers could take on. And they included when they should start discussing these issues and who. So there's some areas for parental education, specifically male fertility. You don't want to get a male getting to be reproductive age without knowing if they're fertile and if that's even a possibility. In-clinic education, because you also want to discuss that with the patient, and also care delivery. So things like contraception counseling, optimizing preconception health should all be done in the CF clinic. They also give ideas for referrals. So number 4 is women with CF prefer early, open-minded sexual and reproductive health discussions initiated by their CF team. So this starts with parental conversations when the children are young. You can even start talking about things like urinary incontinence if they come up in your pediatric patients, starting even 5 to 9 years old. And it's especially important to start self-visits at around 14 years old so that doctors can start asking their teenage patients about SRH. As you can imagine, most teenagers do not want their parent in the room for these conversations. And they also are very embarrassed and want their provider to initiate the conversation. So I've been talking about SRH care in the CF clinic, but what about bringing an OBGYN into the clinic? So last year, Rousset-Jablonski et al. Did a case study in France of bringing a OBGYN into clinic as a consult. So this is not giving a pap smear in clinic, or at least I sure hope no one's ever talking about giving a pap smear right before a PFT. So they had women fill out a survey about what topics they wanted to discuss in their clinic. The OBGYN provided that consult, and if they needed further testing, like a pap smear, they could refer them out to the OBGYN's clinic. So in analyzing the results from the study, they found that the contraception prevalence rate increased to 97%, and the proportion of women receiving OBGYN care increased to 91%. Now, my clinic here in San Francisco did something kind of similar, which is when I did an intake form, and on the yearly form where they ask what you want to talk about, they included sexual and reproductive health on that list. So I was very thrilled to see that, and that's an easy way clinics can initiate the conversation. So now I want to talk about a couple specific topics for conversations. Contraception counseling is extremely important for people with CF because there are many side effects or complications that can occur. So Rowe et al. Did a study looking at what women want in their contraception, and this is specifically CF women. They wanted effective, easy to use, with minimal side effects, and no interference with sexual enjoyment. Contraception is entirely a patient-centered decision, and while there are many misconceptions about contraception among women with CF, it's very important for providers to give that information in a non-judgmental way and allow the patient to make the decision themselves. This is especially important when a patient starts a modulator because, as you heard in the previous presentations, women with CF seem to be getting pregnant at a much higher rate on modulators. So contraception safety is often the question that women with CF want to know, and they will often come to their doctor and say, what is the best contraceptive for me? There is no answer to that because it is all patient preference, but we can answer what is safe and what is most effective at preventing pregnancy. So the safest contraception is all of them for just CF. So the US medical eligibility criteria guidelines created by the CDC are for complex contraceptive decisions, and they're done by disease. So CF was added in 2016, and it showed that all forms of contraception are either safety 1 or 2, according to the guidelines. There are some comorbidities that I will talk about in a moment that might affect this. LARCs are the most effective at preventing pregnancy, but there are many reasons patients will choose not to use them. Some of the most common comorbidities are CFRD, bone density, liver disease, transplant status, and a history of blood clots. So while the USMEC guidelines does have the information about safety right now, there's really so little known about safety at this point that those really are just guidelines. We really need more information, and this could be added to the CF Foundation's registry to track over time. And Emily Godfrey and her team actually started doing a registry pilot program for contraception in CF this year. Another area of reproductive decision-making is another area of conversation in clinics is in reproductive decision-making. CF patients do want to become parents, and a lot of them don't think they can become parents because they have misconceptions about fertility. So when Haley et al. Looked at what are their concerns about parenthood through interviews with CF patients, they found that it was really 4 things. It was health decline, genetic concerns, early mortality, and balancing roles. And when I discussed possibly having kids in the future with my CF doctor, she commented that I might want to consider stopping work if I were to do that and she said she tells that to all her CF patients, whether they have low lung function or high lung function. Just balancing work, CF, and parental duties is a big challenge. So many people with CF think about ways to have a family that is not through pregnancy. So adoption, fostering, surrogacy, and living without children are all valid options. And they're all options that have a lot less medical literature written about them. Another example is when I was having that same conversation with my doctor about surrogacy, she didn't know that surrogacy was not even legal in the state we were in. So there's a lot of information about adoption agencies, foster agencies, surrogacy laws that all vary state by state and county by county, that it would be really helpful if CF clinics were well-versed in their particular area. And that also gets into referring out to these agencies. So many of these agencies, if a CF clinic were to have a list of agencies that other patients at the clinic have used, it could really facilitate patients finding an agency that is familiar with CF. I've heard a lot from people that they want an agency that has had a CF patient so that that agency knows that a CF patient can be a parent. A lot of people still think of CF as a childhood disease. And when you're dealing with something like an open adoption, the parent could discriminate against you because they don't think that you're going to be around to raise their child. There's also many reproductive health areas to refer to, so maternal fetal medicine, fertility clinic, obstetrics, and sexual health, like we heard about urinary incontinence. There's physical therapists, urogynecologists that can help with that too. So finally, there's many resources in development that can help with these conversations. So as I mentioned, I'm part of CFresh, and we got an impact award this year to write a guide to help facilitate these discussions. So the guide will have questions for providers to ask patients, things like, what are your reproductive goals in the next year or 5 years? Questions for patients to ask providers, CF-specific information, psychosocial issues, psychological, knowledge gaps, personal narratives, peer-to-peer advice, and resources. Some of the future topics that we intend to cover are sexual identity, breast health, endometriosis, pregnancy loss, and dating. I'm excited to announce that as of last month, this is now available online at www.cfresh.org. Another resource that is currently available, the Center for Young Women's Health in Boston has created 13 CF-specific sexual and reproductive health guides, and this is for younger and adolescent women with CF. Another project I'm currently working on is a reproductive decision aid tool for women with cystic fibrosis. And so this is something they can go through on their own time to decide about reproductive decisions like, should I do pregnancy? What about fertility treatment? And what kind of birth control should I take? And that is going to be done for pilot testing, hopefully in winter 2020 or spring 21. So some of the key takeaways I hope you got from this presentation are that CF care teams are integral to CF patients' SRH care. Center-specific referral networks can facilitate that care. There are many resources in development and currently available that you can use to help educate yourself and start these discussions. And really the most important is more information and more research is needed. Adding many of these topics to the CF Foundation registry could help get things like what side effects contraception has. So thank you so much for having me today. You can find me over at CFresh or CF Roundtable, and I look forward to hearing your questions at the panel discussion.